today's proceedings. So as we know today, this is the 8th case presentation series which Ampok is joining. And since the last couple of months, we have been associating with ISMBO, and so that the postgraduates across the country can benefit out of this interesting case presentation. So without wasting much time, I request my friend Dr. Nikhil Haridas to take up the proceedings to invite the examiners and the assembly. Nikhil?
Thank you, Boban sir. Today we have a very interesting case and very two very good and senior experienced examiners. I would like to invite Dr. Srilesh, Senior Consultant, Astor MEMS Calicut. Sir has a very good all-round knowledge, and one case presentation in which I was lucky to sit with him. He impressed me with his clarity of thought. And Dr. Deepa is a classic teacher and a good physician from RCC. Ma'am, even though we have not met much, we have heard a lot of you from your students who are here. Without wasting much time, right now we are focusing on the case presentation. Previously we had a mixed mode. Now, but it looks like we need enough adequate time to finish the case presentations and cover all aspects of a particular case. Without much ado, we have Dr. Gopika, senior resident from MVR Cancer Center, with the case presentation. You may start, Dr. Gopika.
Good evening, sir. Good evening, ma'am.
Yeah, good evening. Gopika, you can actually finish it off till this examination part. Then we will discuss.
Yes, sir.
Okay.
Sir, my case is Mr. Ashraf Paramat, 41-year-old male from Malappuram, who is a sales executive by occupation, presented with complaints of swelling in left side of the neck since 7 months duration and abdominal distension since 6 months duration. History of presenting illness. Patient was apparently normal 7 months back when he noticed a swelling in the upper third of the left side of the neck, which was insidious in onset. Initially, it was about the size of a small gooseberry and gradually increased in size to attain the present size, that's the size of a small lemon. It was not associated with the pain, no ulceration or no discharge. 2 months later, he noticed another swelling below the initial swelling on the left side of the neck. It was also initially small in size and gradually increased in size to attain the present size, not associated with pain, ulceration or discharge. No history of loss of weight or loss of appetite. No history of fever, no history of drenching night sweats. He had a history of abdominal distension since 6 months, which was not associated with pain, and no history of swelling in the abdomen. He gives no other significant systemic complaints. Past history, no history of similar complaints in the past. No history of diabetes mellitus, hypertension, coronary artery disease, TB or HIV. No history of previous blood transfusions and no previous history of malignancy. Personal history, non-vegetarian, he takes a non-vegetarian diet, bowel and bladder habits normal. No history of smoking, alcoholism or IV drug abuse. Occupation, he is a sales executive. Sleep and appetite normal and no history of drug allergies. Treatment history, no previous history of previous biopsies. No history of previous radiation or chemotherapy or hematopoietic or organ transplantation. Marital history, he is married since 13 years, has 2 children, no history of multiple sexual partners. Family history, no history of malignancy among family members. Summary, 41-year-old Mr. Ashraf with no comorbidities who presented with complaints of swelling in left side of the neck since 7 months duration, which was insidious in onset and gradually progressed in size, and with complaints of abdominal distension in 6 months of duration, with no other significant personal, family or treatment history. And I would like to examine the patient for further information.
Gopika, just one point. Can you hear me?
Yes, ma'am.
Can you hear me?
Yes, ma'am. Yes, ma'am.
Okay. So first of all, as examiners, we are here to pass you. We are not here to fail you. So just be relaxed, confident and speak. Second point is begin with the end in mind. You have already taken the history, you have taken the examination, you have done your examination. You already know what is your diagnosis and differentials, right?
Yes, ma'am.
That is already clear in your mind. So
yes.
Whatever you are presenting, begin with the end in mind. The end is the diagnosis, or rather the differential diagnosis. So every word that you speak in relation to history, in relation to examination, should be adding to that differential diagnosis. So that is the art of presentation, meaning it is, you are in charge of the exam. So you should be navigating the whole case presentation along your strong points so that you reach your differential diagnosis. And at the end of the next 1 hour, what we expect is we should all be a fan of you, right? So that should be the way you should be presenting. So we have 4 parts in our presentation today. First is a subjective part, the history, which you just completed. Second is the objective part, which is your physical examination. Third will be the assessment, or rather the evaluation. And the fourth is the SOAP. P is the plan. So each part we'll spend around 10 minutes for each, so that we can complete the whole thing in around 60 minutes. And if whenever we, at the end of each part, we'll be asking you a few questions. And whenever any question is asked, just be calm, just be confident. And what you should think is not about your debita or ablof. Think that you are in your busy OPD, sitting in front of your consultant. You see a similar patient in your OPD, and the consultant is asking you a question. What answer would come to your mind? That would be correct in 100% of the situation. So just think of a similar patient whom you have seen in your OPD. Your consultant sitting with you in a busy OPD is asking you, and you are trying to answer. So if you know the answer, just be clear, just be confident, and speak out the answer. If you don't know the answer, there is no need to bluff or anything. Just say that you don't know. And we are not, no examiner is here to criticize you or to say that you were wasting your time, you never came to the OPD, you never did that. Nobody is going to think of any such things. All that we would think is, at this particular point in your life cycle, you don't know the answer to this particular question. That's all. You knew answers to thousands of other questions, which, unfortunate for you, I didn't ask you. That's all. And the next moment, I'll tell you the answer to that question. So you know the answer to that also. So just be cool, confident. So we have finished our first part, and that is the history part. Can you just go back to your first slide? So you spoke about the presenting complaints and the duration. So from this, just the first 2 lines, what is your thought process about the probable disease or the probable natural history of the disease that this patient is having? Or in other words, if you're thinking in terms of lymphoma or hematological malignancies, what are the 2 diagnoses which are automatically out of your mind when you see this history?
Since a history of 7 months duration, since a longer duration, and considering a lymphoma, it would be a low grade or indolent lymphoma rather than a aggressive lymphoma.
So even if you don't think of lymphoma, what you should think is it's something indolent. It is something low grade because you have a history of 7 months. So if you're thinking in terms of lymphoma, what diagnosis would be completely out of your mind?
Hodgkin's and TLBC.
7 months history, something which would be completely out of your mind, meaning something which is very, very aggressive, which doubles in say 24 hours.
Lymphoblastic lymphomas.
Yes, leukemias and Burkitt's lymphoma would be completely out of your mind when you have such a long history. That means you are dealing with something low grade, something indolent. So that's what you can say from the presenting complaint. Now, one more thing, you spoke about gooseberry and a small lemon. So what is the approximate size of a gooseberry and a small lemon?
About 1 gooseberry, 1 into 1.
So what I'm trying to tell you is, see, I'm a very benign examiner. I'm not a toxic examiner, but this is what happens in the exam. The examiner would, out of no reason, make a lemonade out of you. So we are presenting a DM exam, right? So there is no need to say gooseberry and lemon. You can definitely say the size, and nobody is going to question you for saying the size. So that is because what is your strong point? Your strong point is not gooseberry size. Your strong point is lymphoma, evaluation of lymphoma, IHC, PET-CT. Those are your strong points. So the art of presentation is take the examiner to that strong point at the earliest without getting stuck at these minor points. Okay. So I'm not finding fault with you. in future, when you present, make sure that you don't get your examiner stuck in these small minor points. Okay. The next slide.
Okay.
So why did you say that there is no history of loss of appetite, fever, drenching night sweats, all that?
Ma'am, these are all B symptoms which are present in
Okay.
lymphoma.
Very good. So what are the B symptoms? The classical question.
B
No
symptoms,
discussion will be over without asking B symptoms.
fever more than or equal to more than 100.4 degree Fahrenheit or 38 degrees Celsius for more than 4 weeks, drenching night
Okay.
sweats for more than 4 weeks, or weight loss, unexplained weight loss more than or equal to 10% for a period of 6 months, or more than 7.5% for a period of 3 months.
Okay. Very good. But is there something else which is missing in what you spoke just now? Okay. The first thing which you said was fever. So a fever of more than 38 degrees Celsius for 4 weeks, that's fine. But it should be a persistent, unexplained fever. Suppose you had a lymph node, you did an biopsy, it's infected, there is an abscess there, and the patient has a fever spike of 101. That doesn't qualify for a B symptom. So there should be documented fever, it should be a persistent fever, and it should be an unexplained fever. Second point is you spoke about weight loss. Why I'm saying that is I made a soup out of myself during my DM time. Second is weight loss, right? We all rattle out 10% in 6 months and all that. I had a patient, a 40-year-old lady, an engineer, a case of, I think, low-grade lymphoma. She was fit and fine. The only thing was she had weight loss. I calculated it was 10%, everything was fine. And I presented to the examiner, wrote the treatment plan, everything. Then my teacher, my professor just asked the patient just one question. Since how long you have been dieting? So she was a very health conscious person. She was going to the gym 5 days a week. She was on a diet. So this was an intentional weight loss. So that does not qualify for a B symptom. So it should be an unexplained, unintentional weight loss of more than 10% for 6 months. So that's a very important point. So that day I landed up in a soup. So I still remember that. Third is when you say night sweats, it should be drenching night sweats. We all experience night sweats, right? During the summer season. So we all get night sweats, or say you have hot flushes, you feel night sweats. So classical is it is drenching night sweats, which make you change your clothes in the night. You are completely drenched in it. So that is what is B symptom. Why I'm saying that is it's a very pet question of every examiner. And if you say all the points, you can easily sail through. Okay. Next, you said about abdominal distension of 6 months, right? So what are the different thought process that would come to your mind when you think of abdominal distension of 6 months? From the perspective of lymphoma, because you have already completed your history, examination, everything, right? What are the different ways in which a patient of suspected lymphoma can have abdominal distension?
Abdominal lymphadenopathy, he might be having lymphadenopathy
Very
or
good.
hepatomegaly, splenomegaly, ascites.
Okay. Anything else? Very good. All the points which you said are right. Lymphadenopathy, hepatosplenomegaly, ascites. Then, are there any lymphomas which can have GI involvement?
Yes, ma'am.
Direct.
Gastric lymphoma, malt lymphoma.
Okay, very good.
Splenic.
Okay.
Splenic margin zone lymphoma.
Okay.
Small bowel
So,
lymphomas.
Which one?
Small bowel lymphomas.
Okay. So whatever you said is right. Retroperitoneal, bulky lymphadenopathy, organomegaly, ascites, direct GI involvement by lymphoma. You can start from the stomach. Stomach is involved in maltomas. Yes. And if you have ileocecal, it's usually Burkitt's. Then you have colonic polyps, that is it, Mantle cell lymphoma. So those are some of the DDs. You have a long list, but at least remember a few of them. So whenever you say anything in your history, that's what I said, begin with the end in mind. So whatever you write in your history, whatever you present in your history, be ready with an answer. because no examiner comes prepared with a set of questions to ask you. Whatever question the examiner is going to ask you is based on whatever you have written. So whatever you write, just make sure that it's your strong point and you can confidently speak for a minute or so about each question related to that. Can you go to the next slide? So past history is fine. You said that there are no similar complaints, no tuberculosis. Personal history, you said about the occupation, patient is a sales executive. Do you think there is any significance for that?
No, ma'am, here in this patient, no significance, but.
Okay. Do you think occupation is important in any way in case of lymphoma?
Some HIV associated lymphomas usually.
Okay.
Drivers of HIV
Okay.
associated. Then,
Any chemicals, anything which have been postulated?
agricultural pesticides.
Okay, very good. So why I'm asking you is, sometimes somebody would ask you something like that. So in that case, just be confident and speak. Don't say that I don't know for these small things. Okay, next slide. So you mentioned no history of biopsy, radiation, chemotherapy, and organ transplantation. Why did you mention organ transplantation?
There may be post-organ transplantation lymphomas.
Okay.
There.
Have you read about it?
Yes.
So that is why I said, see,
Yes,
if there is no reason why you should just put it there. Usually when you present, you don't put it there. So if you write it there, it's very good, you can write, but make sure that you have read about post-transplant lymphoproliferative disorder, so that the examiner will ask you more about it and then you can keep on answering. So it's important to ask about history of radiation, chemotherapy. How do you ask for a history of chemotherapy to a layman, a person who is, of course, he's educated, he will know. If it's a layman coming from the village, has no idea about what chemo is all about, how are you going to ask a history of chemo to a layman who doesn't know what chemo is, a past history of chemo?
according to, in this cases, lymphomas, we can, anthracyclines we can use.
Okay, how will you ask the history of anthracycline?
Based upon color, adriamycin,
Okay. Red color. Okay.
Mitoxantrone, blue color.
Okay.
Then other.
So you can just ask the patient, right? Have you taken any red colored medicine, which is given over 30 minutes, after which your urine had a reddish discoloration? Some patients would, that patient would definitely remember something bright red causing reddish discoloration of urine that they will never forget. So if you just ask chemo, some patients may not even know. So that is important. Mitoxantrone, as you rightly said, methotrexate, a yellow colored medicine, which was given after admission, which was lasting for 24 hours and they were stuck to the ward for days together with fluids, that they would remember. Rituximab, a very expensive drug, which was given in a very slow infusion. All those things the patient would definitely remember. Can you go to the next slide? Okay, so you have summarized it quite well. A 41-year-old, no comorbidities with basically cervical lymphadenopathy, which is insidious in onset, associated with abdominal distension. Okay, very good. Dr. Shrilesh, anything to add in history?
Yeah, nice, Diva doctor. You have almost explained everything. But I think, Gobika, you should actually elaborate this abdominal distension. So basically, with this history, do you have any other differentials?
Sir,
Patient has got a 41-year-old male has got abdominal distension, neck node. So why always lymphoma? Could it be some solid tumor? 6 months history is not a very long history. It is not very short also. So 6 months history of some GI malignancy can present like this. Left. Which all thing can present like this. So I think you should elaborate about the abdominal distension more, whether it is ascites, whether it is progressive. You can just discuss whether previous tapping has done or not. Again, reasoning. So some GI malignancies, especially we have seen patients presenting with the CA stomach. With the CA stomach may not be having any vomiting GI symptoms, but can present with an neck. Have you seen that neck node? Yeah.
Sir,
We have seen some patient presenting with some neck knot, then but classical symptom of CA stomach is usually weight loss, which is not there. Again, patient can have a stomach, CA stomach can have neck knot and later abdominal distension ascites. So it's also possible. So you should not always think that it is lymphoma. It could be some other thing also. Like when you say history, I think you have to allow, especially the abdominal distension, you just said some 1 or 2 lines.
Yes, okay.
So it could be anything. Actually, from history, we cannot say it is 100% lymphoma. It could be some other differential diagnosis. I would consider is some abdominal malignancies with left supraclavicular node. It's also possible, right?
Yes, sir.
Only one thing odd is, especially GA malignancy, there will be severe, by 6 months, there will be some severe weight loss and all. The resting, everything, I think Dr. Deepa has clearly explained. So you can proceed, I think, to the examination.
I'd like to examine the patient after explaining the procedure and getting informed consent, and he's been examined in a well-illuminated room with adequate privacy. And general examination, he's conscious oriented, moderately built and nourished, echo performance status 0, height 176, weight of 80 kilogram, body mass index of 25.8, body surface area of 1.9, no pallor, icterus or pedal edema, no petechiae or purpura. Generalized lymphadenopathy is present, which I would like to describe in the local examination findings. No facial puffiness, engorged veins over the chest, skin and thyroid normal. Vitals, pulse rate 80 per minute, blood pressure 120/80 millimeter mercury in right upper limb in sitting posture, respiratory rate 18 per minute, abdominothoracic, temperature 96.4 degree Fahrenheit. Local examination or lymph node examination, inspection, 2 discrete swellings in left side of the neck about 3 into 2 centimeter in upper third and 2 into 2 centimeter in lower third. And in right side of the neck, swelling of size 3 into 2 centimeter in middle third, no redness, discharge or sinuses. Coming to palpation, cervical lymph nodes, left level 2 lymph node of 3 into 2 centimeter, left level 4, 2 into 2 centimeter, right level 3, 3 into 2 centimeter, and bilateral level 5 lymph nodes, multiple lymph nodes, largest of which is 2 into 1 centimeter. Bilateral axillary lymph nodes are palpable. Left axilla 3 into 2 centimeter in central group. Another lymph node 2 into 1 centimeter in anterior group. Right axilla 2 lymph nodes, which is largest of size of 3 into 2 centimeter. And bilateral inguinal lymph nodes are palpable, largest in the right side 3 into 2 centimeter. All the lymph nodes are mobile, not matted, non-tender, no local rise of temperature, soft in consistency, smooth surface, regular borders. Skin over the lymph nodes normal, no discharges or sinuses, and no popliteal, epitrochlear or occipital lymph nodes are palpable. Coming to systemic examination, gastrointestinal tract, oral cavity, no gum bleeding, no gum swelling or bleeding, no ulcer or swelling inside in the mouth. Tonsils are normal. Per abdomen examination, inspection, per abdomen distended, umbilicus flushed with skin, all quadrants move equally with respiration, no distended veins, scars or sinuses. Palpation, liver palpable, 4 finger breadth below the right costal margin, non-tender, smooth border and surface, spleen was not palpable. Percussion, no shifting dullness or fluid thrill. Auscultation, no hepatic fluid. External genitalia, no testicular swelling. Central nervous system examination, higher mental functions, cranial nerves, sensory motor system and reflexes were normal. Skull and spine, no tenderness and no sternal tenderness. Cardiovascular system and respiratory system is within normal limits. Coming to summary, 41-year-old male, Mr. Ashraf, with no comorbidities, who presented with complaints of swelling in left side of the neck since 7 months duration and abdominal distension since 6 months, and on examination, bilateral, cervical, axillary and inguinal lymph nodes palpable, which are mobile, soft, non-tender, and with hepatomegaly, and no other significant systemic findings. I'd like to proceed with further investigations.
Okay, Gobika, very good. Can you go to your first slide of examination? Okay, so you've presented very nicely. Just a few points. You have written ECOG performance status 0. So what is your comment on that? What do you mean by ECOG performance status 0?
is able to do all daily activities without any exertion or
Daily activities. Okay. So as a homework, what you need to do is, it's a question which will be asked invariably in every exam. So what is performance status? What is the definition of performance status? What are the different ways in which it can be done? ECOG, Karnofsky, how is it done in pediatrics? These are pet questions asked everywhere. That you have to be very clear when you go for your exam. Let's not discuss that because we'll be spending a lot of time on that. Just one point, in exam, it's better not to mention ECOG performance status 0. What it means is the patient is able to do every activity. It's not activities of daily living, every activity which he could do before his diagnosis or before his disease status. Here you have a patient with cervical lymphadenopathy with abdominal distension who is so troubled that he has bothered to come to the hospital, right? We didn't go home and screen him and find him. So that is the importance of being like, if you had written PS1, I would not have asked you this question. So it's better not to irritate your examiner with such things. So just say ECOG PS1 because a patient has an abdominal distension is symptomatic. So please go and read up what is the definition of each of them. Second thing is you have mentioned height, weight, BMI and BSA. You are sure, right? This BMI and BSA is right.
ma'am. Sorry.
You are sure, right? This BMI and BSA that is calculated is right, no?
Yes, ma'am.
This is what happens in exam. So if I ask you again, you will get confused because right now you have your calculators with you, but at the time of exam, you may not have the luxury of having a calculator with you. So if you have height and weight, if you don't have the time to calculate BMI and BSA, write it. And there is no harm in telling the examiner that I couldn't calculate it, but never cook up and write your value.
Okay.
I'm telling from our personal experience, like, of course, not for the final exam. We had, like, once I was, one of my colleague was presenting a case to Sudeep sir. We wrote height, weight, BMI, BSA, some value. So we went to the next line. Suddenly, sir said, just hold on for a minute. Deepa, can you calculate this BMI and BSA with your calculator? So it was totally wrong. So it doesn't make any difference. Only thing is you will lose your confidence if some such things are picked up by the examiner. So if you can calculate, you just say what is the BMI and BSA. If you don't get the time to calculate, don't cook up something and write the proper value there, just from the point of view of exam. Okay.
Okay.
Then about lymphadenopathy, can you go to the next slide? Okay, so what you're saying is you have generalized lymphadenopathy. And when you say about the palpation, especially the age-old teaching is whenever you palpate a swelling, what is the first thing that you do? You look for local rise of temperature and tenderness. And the rest, everything, whether it's mobile, everything comes after that. So especially with examiners, they might ask you why you have put the temperature and all towards the end. So just confidently just speak with a flow. That next slide. So about the lymph node, when you say, you can say that the lymph nodes are, there is no local rise of temperature. The lymph nodes are not tender. So there are non-tender, mobile lymph nodes, soft in consistency, smooth surface. So just rattle it out confidently in a row so that nobody is going to stop you and ask further about it. Why did we talk about epitrochlear lymph node specifically?
Epitrochlear lymph nodes are more common in mantle cell lymphomas.
Is it specific for Mandel? You can't get it in
Not
follicular.
specific. More
So it's
common.
more common in it's more common in non-Hodgkin's compared to Hodgkin's lymphoma. That is all. Okay, but there is no hard and fast rule. Next slide. So there's nothing significant, no, except for a hepatomegaly. So can you go to your summary slide of examination and history together? Okay. Dr. Shrilesh, anything to add?
Nothing. So again, what are your DDs by
Differential
this
diagnosis.
differential diagnosis after your examination?
Since generalized lymphadenopathy of this 7 months duration and with no other symptoms of infection, I'd like to give first diagnosis as lymphoproliferative disorder. So.
Okay. GI malignancy. So I said after history, abdominal distension, that would be GI malignancy.
Examination findings does not correlate.
Which examination finding? Which examination finding specifically? Again, this lymph node, you said it is soft node. Usually, I think.
Usually malignant, solid malignants, they are hard to form, mostly hard in consistency.
Yeah. Then again, this soft, this liver is actually,
Distribution of
you
the
said it is regular border, right? So soft node, I think, I don't know. Diva, is it okay to say soft node in lymphoma? Is it fine?
So what is the usual type of node? There is nothing absolute in medicine. So if in your exam you're getting a soft node, there is no need to cook up and make it hard or firm, but you should be very sure that it is soft. Of course, now since it's a virtual platform, you have all the liberty to say, and we trust you and we believe you. But in the exams, just because we said it has to be firm, don't say firm, because you are a clinician. So whatever you say, you should be able to confidently substantiate it in your exam. So usually what you see is a firm node, and it's usually a hard node in secondaries and from a solid malignancy, but there is nothing absolute. So if you are feeling a definitely soft node, of course we believe you, but usually it's a firm node. Okay. Anything else which goes against a GI malignancy? What is the distribution of these nodes?
Nodes, GI malignant, these are upper cervical nodes, usually nodes in lower cervical nodes or supraclavicular lymph nodes, more in favor.
What about axillary node?
Axillary node? Can we...
How common is it to see generalized lymphadenopathy with, say, CS stomach?
It's not common.
Okay, so just confidently say that, that's all. I don't say that every CS stomach will have generalized lymphadenopathy. That's what I said. Just think of the patients of CS stomach whom you have seen in your OPD and confidently say that. Just because an examiner has asked doesn't mean that it should be. The examiner means to say that there is generalized lymphadenopathy in CS stomach. So think of a patient and just confidently say, that's all. Okay. So what are your differentials at this point? One, you said lymphoproliferative disorders.
Disorder.
Can you say some, of course, you have to do a biopsy and everything. What would be the different differentials? So you have a malignant, and do you want to entertain any benign non-malignant etiology in this patient? If you want to entertain, you say. If you don't want to entertain, it's fine. But whatever you say in differential, you should have points for and against.
No, ma'am. No history findings as of infectious causes or like fever or anything. So, like TB, HIV, that's not, and also no history of weight loss. So it is not common for TB, HIV.
So what are your differentials at this point after your history and examination?
Among the lymphoproliferative disorders.
Sir, since this a history of about 7 months and also gradually progressing in size, so it may be an indolent or low-grade lymphomas, most probably NHL follicular lymphomas. Like.
So if I tell you that I want 4 differentials, what will be your differentials in lymphomas? Of course, you said you are not entertaining a non-malignant cause like infection. So that's fine. You have substantiated and beautifully told us that you don't want to entertain that. That's fine. So among the lymphoproliferative disorders, as you rightly said, it's a long history, insidious onset, it's gradually progressive, and it's a history of 6 months. So you are entertaining low-grade pathology, low-grade lymphomas. So what are the, say, 4 diagnoses or at least 3 differentials which you would keep in your mind?
Follicular lymphoma.
Okay, very good.
Then nodular lymphocyte predominant Hodgkin's lymphoma. It's a young patient.
Anything else?
CLL, SLL.
Okay.
Then marginal zone lymphomas.
Okay, so can you substantiate points for and against each of this? One, you said follicular lymphoma.
Lymphoma.
Based on history and examination, what are the points for follicular lymphoma in this case?
Longer duration means history
good.
of then no B symptoms. B symptoms are more common in Hodgkin's lymphomas.
Okay, so I think my question was not clear to you. So when you are asked about differential diagnosis, what you should be, yes,
Age
what
of
you
the
should be,
age of
tell
the
me. Okay,
age
so
of
what
the-
you should be saying is you have to tell the differential diagnosis in order. Say 1 or 1, 2, 3, 4, and say points for and against. Nobody is going to treat a patient based on your history and examination. You'll definitely go to the evaluation part. So just confidently say that based on a history of 6 months duration with insidious onset, gradually progressive disease of generalized lymphadenopathy with hepatomegaly in a young male, my differentials would be 1, follicular lymphoma, 2, SLL bar CLL, 3, Hodgkin's lymphoma, 4, mantle cell lymphoma. And then you say pain points for and against. For follicular lymphoma, generalized lymphadenopathy, hepatomegaly are points for follicular lymphoma. What is a point against CLL or SLL? The usual age group is
more than
about 60.
60.
Yes, below 50 years, it's seen only at 10%.
10%.
Suppose I say it's mantle cell lymphoma. What will you say that something which is against or which is less likely? Again, it's the age. It's usually a disease more common in the elderly. Suppose I say it's hairy cell leukemia. Do you think I'm right? Do you think I'm wrong?
Hairy cell leukemia with splenomegaly. Splenomegaly will be more common.
Okay. What
Then
is grossly odd in this clinical presentation against hairy cell leukemia?
leukemia.
So hairy cell leukemia, the usual presentation is with splenomegaly. And what is uniquely absent in the CLPD of hairy cell leukemia is lymphadenopathy. So when you get generalized lymphadenopathy, hairy cell leukemia comes down in your list. Or maybe it comes out of the list. Because if you get a patient of hairy cell leukemia with generalized lymphadenopathy, your diagnosis is almost 99% wrong. So you have to discuss with your pathologist. Can you tell me what is the reason why you don't get lymphadenopathy in hairy cell leukemia? If you know, you say. If you don't know, it's fine. That's only a distinction question. So that's related to L-selectin and CCR7 in the hairy cell. That's fine. So if you know that, you say. If you don't know that, it's perfectly fine. So you have spoken about points for and against. So I think, okay, so you have completed your history, you have completed your examination, you made a fairly long list of differentials. Now, how are you going to proceed further? What will be your first investigation? Not this patient's. What is the first investigation that you're going to do in this patient?
Routine blood investigations.
What do you mean by a routine blood investigation?
Like complete blood count, renal
Yes.
function test, liver function test, and since we are suspecting lymphoma, we have to do clinical biochemistry parameters like for looking serum electrolytes like potassium, phosphorus, calcium. Then
Okay.
viral markers.
Okay. So what is your first investigation which you said?
Complete blood count, which includes
Complete blood count. Okay. So I'll give you the complete blood count of an imaginary patient. Suppose a hemoglobin is 8. Total count is say 2 lakhs. And platelet count is 1.6 lakhs. So what is your next investigation going to be? I'll give you a few choices. One is peripheral smear. Second is bone marrow. Third is an excision biopsy of the lymph node. 4 is a PET CT. What is going to be?
Peripheral smear.
Peripheral smear. Okay. Why do you do a peripheral smear here?
Can malignant cells or blast cells we can
Are you going to expect a blast in this particular patient? We are discussing about this particular patient.
This
A patient with a 7-month history who is so well preserved. If you see blast in the peripheral smear, what is your diagnosis going to be?
lymphoblastic lymphoma. Acute
The
lymphoma.
diagnosis is going to be leukemia, right?
Yes.
And you have a count of 2 lakh. Do you think this patient would be having leukemia?
No, ma'am, about this patient or ma'am told
We are
one.
discussing about this patient. So this is a patient with generalized lymphadenopathy,
Then this
7 months
patient.
duration, with a
Okay.
total count of 2 lakhs, hemoglobin of 8 and platelet count of 1.6 lakhs. You have
Then-
done a peripheral smear.
Okay.
So why did you do a peripheral smear? What were you expecting? A chronic history.
A
Said
CL
6 months due.
chronic lymphocytic leukemia.
Okay, so you are expecting a chronic lymphocytic leukemia.
That's
So what
called
would you expect in your peripheral smear in such a patient? So how do you describe the peripheral smear? You'll describe the RBC series, you'll describe the WBC series, you'll describe the platelets, right? So RBC, hemoglobin is 8. So the patient is anemic. So the pathologist will look and characterize the type of anemia. Is it microcytes? Is it macrocytes? Is it normochromic? Is it hyperchromic? And what are the 2 specific features which you would see in the peripheral smear of a patient of chronic lymphocytic leukemia? So it's basically, you will see absolute lymphocytosis and smudge.
Blood cells.
Okay, good. What is the next investigation you are going to do to characterize this 2 lakh count of WBC?
Flow cytometry.
Yes, very good. So what do you expect in the flow cytometry? It's okay. So in flow cytometry, yes, tell me.
CD markers for
Yes.
specific for
If you know,
CLL.
please tell me.
CLL. We do CD 5, CD5 positive.
Very good. Yes,
CD 23 positive.
very good. It's a B cell, right? So what will be positive?
CD 10. CD20.
Okay. Anything else? Anything that would be negative?
CD.
Okay, that's all right. So you can just read it up. It's called Matute scoring. Matute scoring after the name of the Saipa who described it. So it's basically CD5, CD23 positive, CD19 positive, 20 dim, FMC7 negative. That's okay. You can go and read it up. So I think you have not prepared for CLL, right? So what I'm trying to tell you is, especially from the point of view of exams, always I'm telling you positively, don't feel bad or don't get stressed with an open mind. Meaning, even if the skilled is a very close friend of yours, and if he is a genuine friend of yours, he will not tell you what the diagnosis is. Because what happens is when you go for the exam, you get totally biased. I think you knew that it's probably follicular, right? So
Yes.
then what happens is your mindset is totally focused on follicular. So when the examiner goes in a different track, you would know about CLL, but you will lose your confidence. So
Yes.
always in exam, go with an open mind. So to just help you out, I'll tell you the patient's age is 41. So it's below 50 years, CLL is very, very rare. It's seen in less than 10%. So I'll change the whole scenario. Okay. So this is not CLL. Patient's complete blood count, as you said, all the investigations, basic investigations, you said beautifully. Patient's blood counts are normal. So can you go, did you have your investigations of this patient?
Yes, ma'am.
Okay, very good. So as you can see here, blood counts are perfectly normal. ESR is normal. Renal function is normal. LDH is 633. So what is your comment on this LDH of 633?
LDH may indicate a tumor burden.
Is
Maybe
it normal
English
or is it abnormal?
abnormal, ma'am. This
What is the normal range of this LDH?
350.
350. Okay. So it's always important to see the normal range. Okay. Because you can have different ranges in different labs. So 633, obviously it's quite high. So count is normal, ESR is normal, LDH is high. beta-2 microglobulin is high, viral markers are negative. So how are you going to proceed with investigating this patient?
After this routine blood investigation, I'd like to do a staging proceed with a PET scan and followed by a biopsy of the lymph node.
Very good, excellent. Why in this patient you want a PET before a biopsy?
Since we are expecting or suspecting a low-grade lymphoma, since we are able to take a PET scan, we can identify the maximum SUV value and we can take biopsy from that. Plan the biopsy according to the PET CT.
Okay, so if you had said this answer after the history and examination, I would have been quite unhappy. But after this particular slide, and since patient hasn't had a biopsy done so far, after this slide, when you said this answer, this is an excellent answer. So that is how your answer changes from situation to situation. Just before this slide, if you had told me that I'll do a PET before a biopsy, I would have been a bit unhappy. But after this particular slide, when you said PET and then PET directed biopsy, I'm very happy about your answer. Can you tell me what is the reason?
Ma'am?
See, just before this slide, we were just talking about an indolent lymphoma. The patient is so happy, 6 months, just small nodes. And the patient has now come without any B symptom. The patient is so asymptomatic, right?
Yes,
Patient may not even have an indication for treatment from what you described, right? So for such a patient, if you say PET followed by a biopsy, I may not be very happy. Of course, you are not wrong. But after this particular slide, when you said PET followed by biopsy, I'm very happy. What is the reason? It's because of LDH.
yes.
Okay. So you said that without seeing this, but that is important. So the LDH is quite high. So that is why this answer of yours is very appropriate in this particular situation. So, okay. So how are you going to categorize the different investigations you are going to do? So you have completed your subjective part history. You
Yes.
completed your objective part, that is assessment. And now you are in your assessment and evaluation of a suspected lymphoma, right? So
Yes,
what are the 3 broad categories in which you are going to classify your investigations?
Baseline investigations, staging,
Okay.
diagnostic investigations, and
Very good.
staging investigations.
Okay. Anything else?
Prognostic markers.
Okay. So think for any, maybe for any malignancy, when you have to present in your exam, you can say that I would divide my investigations into 3 broad categories. First is investigations for reaching a diagnosis. Second, investigations for staging. And third, investigations to assess the fitness of my patient for the treatment that I'm going to plan. So say this, and then you rattle out all the different investigations in each category. The good thing about this is your examiner would be so impressed that you have a very clear thought process. Your clarity of thought is very good. So even if you miss out on 1 or 2 in each of this, nobody is going to screw you up. So investigation for diagnosis. What is going to be the investigation for diagnosis in this particular patient?
Lymph node biopsy.
Okay. What lymph node biopsy? Can you substantiate it with any adjectives?
Excision lymph node biopsy.
Very good. Why do you want an excision lymph node biopsy? If I say FNA, is it not good enough?
Ma'am, we have to do immunohistochemistry. So FNAC.
Okay. Before immunohistochemistry, what is the first thing that you see?
Excision biopsy, we have to know the architecture of the lymph node.
Very
Full
good.
architecture.
Yes.
Then full grade may be different. So sometimes 2 grades may coexist within a single
Very
lymph
good.
node.
Excellent.
Sometimes in Hodgkin's lymphoma, the number of reads Sternberg cells may be low. Percentage of malignant cells will be low. So we have to look for the entire lymph node. And
Okay.
follicular lymphomas, some this abnormal follicle, it may mimic the normal follicle. It is different, difficult to differentiate between abnormal follicles and normal follicles. So the entire should be taken.
Excellent. So diagnosis of lymphoma is first, you need the morphology in HND. HND is just like history and physical examination for a clinician. So first you need morphology with HND, followed by immunohistochemistry. So lymph node architecture is the most important thing, which obviously you will not get in an FNA, And second, immunohistochemistry and the various reasons which you said. So first, you will do a lymph node biopsy. Second, for staging, what all you will do? Staging investigations.
PET-CT and bone marrow aspiration and biopsy.
Okay. Which are the lymphomas where you will not do, I'll repeat, where you will not do a PET-CT, or a PET-CT is not going to add much to your diagnosis?
CLL, SLL.
Very good.
Lymphoplasmacytic lymphoma.
Okay.
Marginal zone lymphoma and mycosis fungoides.
Okay, very good. So basically low-grade lymphomas like CLL or SLL and marginal zone lymphoma, you wouldn't do a PET. Now, which are the of course, in all others you can do. Then, will you do bone marrow in all patients? Any diagnosis, any histology where you can do away without a bone marrow?
In Hodgkin's lymphoma and DLBCL, if PET scan is if it is positive or negative, we can avoid bone marrow aspiration and biopsy.
Excellent. Okay, so if you have done a PET, you can do away with a bone marrow in Hodgkin's and in DLBCL, of course, with a few caveats which you can read up. So do you have this?
We have to do bone marrow aspiration.
Yes. So in this patient, you should be doing a bone marrow. So do you have the patient's PET-CT with you?
Yes, ma'am.
So can you just read the first line?
Ma'am, the first slide, no?
Yes.
Hypermetabolic, predominantly intense, multiple discrete conglomerate lymph nodes above and below diaphragm, splenomegaly with diffuse hypermetabolism and multiple omental, peritoneal, subcutaneous and intermuscular deposits.
Okay. So do you think this line, this information is enough for you, or you need any much more information? Even you haven't done a biopsy, right? You are planning to do biopsy, seeing this PET-CT.
SUV, standard uptake value of the lymph nodes and size of the lymph nodes. Size of the lymph node.
Why is that important? How will you choose your lymph node for biopsy?
More the standard uptake value, the yield will be more with more high standard uptake value.
So in this particular patient, you have gone through your PET-CT, right? Which was a site with maximum SUV uptake?
Cervical lymph nodes.
What is the status of intra-abdominal nodes? From your history, it seems abdominal nodes would have higher SUV. Yes, as you can see here, retroperitoneal nodes have an SUV of 18 or 19, right? Okay. And cervical, what is the SUV? So I think left cervical node is 2.1 with SUV of 16. Right cervical node is SUV of 9. And right axillary is SUV of 15. Retroperitoneal has an SUV of 18. And subcutaneous deposits have SUV of 6. So why I asked you this question is, the site of biopsy is decided based on one, accessibility. Second, what is most likely to be representative. And third, if you have a node which is clinically rapidly increasing in size. These are the three factors which are going to help you to choose your appropriate biopsy site. So in this particular patient, which is a site with maximum SUV, you said you will biopsy that, right? So that is retroperitoneal node, which has an SUV of, I think, 18, right? Which is the next site with the maximum SUV? It is a left cervical, which has an SUV of 16.
16.
When you go to the picture, see, as you can see here, the abdominal nodes are lighting up so much, right? Yes. So this doesn't look like a usual low grade. So that is the importance of taking your proper history, examination. This is like a jigsaw puzzle. Put all the pieces together. History, examination. Even if your biopsy report comes as follicular lymphoma grade 2, I'm not going to go by the report. I'll call up the pathologist and discuss with the pathologist that this is my scan. So here you have SUV of 19 and 20 in the abdominal nodes. You have an SUV of 16 in the left cervical node, SUV of 8 in the right cervical node. So if this is my patient and the patient has not done a biopsy before, what will be my appropriate site for biopsy? I would choose the left cervical lymph node. Why? Because it's more accessible than an abdominal lymph node. And from abdomen, you are going to do a core biopsy. An excision biopsy, a complete node left cervical would be much better to give me a diagnosis. Between left and right, both are equally accessible. Why am I doing the left instead of the right? That's
sorry,
because the SUV uptake is 18 for the left cervical and it's only 7 for the right cervical. So if you are taken biopsy from the right cervical node, I can tell you that your histology is going to be, say, follicular lymphoma, grade 1 or grade 2, and you are going to undertreat the patient. Am I clear to you? So that is, so we did a PET, we identified the different sites, nodal areas, we identified the size of the nodes in each of these areas, we identified the areas with the maximum SUV. And out of the sites with maximum SUV, see which is the one which is most accessible and choose the site of biopsy from there. Is that clear? Do you want me to explain further? Okay. So I hope you have taken biopsy from the most appropriate site. So which would be the most appropriate site for this patient?
left cervical.
Yes, very good. So you would have chosen left cervical node as a site of biopsy for this particular patient. Can you go to the next slide? Okay, next one. Okay, excellent. So you have chosen left cervical lymph node. So that is how this site has to be chosen, right? If you had chosen a right cervical node, your biopsy report would have been something different. So that is the importance of choosing appropriate investigation. So you have reached a diagnosis. So what is your diagnosis here? Left cervical lymphadenopathy, left cervical node biopsy. What is your final diagnosis here?
Follicular NHL follicular lymphoma grade 3A.
Okay. So you can see some words, centroblast, centrocyte, all that there. So
Yes.
how do you grade follicular lymphoma?
Follicular lymphoma, according to WHO classification, it is graded based on the number of centroblast. Grade 1
Okay.
is 0 to 5 centroblast per high power
Okay.
field. Grade 2 is 6 to 15. Grade 3 is more than 15, and 3 is divided into 3A and 3B. 3A is
Okay.
presence of centrocytes and sheets of centroblast comes in 3B.
Okay, very good. So what are these centroblast and centrocytes?
Centroblast is the cells in the germinal center of the B cell.
Okay.
Centrocytes are small cleaved cell. Actually, in the dark zone, this centroblast are present in the germinal center. It's
Can you
after-
elaborate something about dark zone and light zone? What exactly happens in the B cell ontogeny? What happens in dark zone and light zone? It's
in the
okay.
B
If you
cell,
know, you tell me.
B cell in the germinal center, B cell differentiation occurs after this new B cell enters into the germinal center. This cells lose their antigen and they surface antigen and they become centroblast. That is, they are large non-cleaved cells which lose their surface antigen, and they undergo some somatic hypermutations and
Very good.
immunoglobulin class switching, and they undergo and they develop into centrocytes. The centroblast accumulate in the left side of the germinal center, which becomes the dark zone. And after maturation, they become the centrocytes, which accumulate at the
Excellent.
opposite.
Okay, that's fine. Excellent. So that's what I said. So be clear with your answers. If you know B cell ontogeny, speak it out confidently. Because when you are having a starting trouble, then I thought, okay, maybe you don't know that. So whenever you know something which is like you are clear about it, which you said very beautifully, germinal center has a dark zone and a light zone. Dark zone, as the name implies, it's dark. Why it is dark? Centroblasts are large cells which have a large nucleus. So nucleus obviously will make it dark. Centrocytes are small cells, so that would be the light zone. What happens in dark zone and what happens in light zone? So the way I remember is you do shameful things in the dark, right? So it is somatic hypermutation and affinity maturation. Those are the things which happen in dark zone. And if you have to have light, what should you do? You should switch on the switch, right? So class switch recombination happens in the light zone. So of course, B cell ontogeny is a beautiful topic, which you should be clear. You can learn about it later. So from this IHC, you said CD20, CD10, BCL2 are positive. What comes to your mind for each of these IHC markers?
These are B cell markers,
Substantiate your diagnosis.
20 and CD10 B cell markers.
CD20 is a B cell marker. CD10, what does it tell you about the B cell development?
It's a germinal center marker,
Very good. And BCL2?
post germinal center marker. And
Not really. Okay.
follicle
BCL2 is an anti-apoptotic protein. CD5, if it was positive, what would have been your differentials?
CD5 positive, it is CLL,
Very good.
mantle cell lymphoma.
Very good. Between CLL and mantle, how would you have differentiated based on your IHC?
CD5 positive, then we'll do CD23.
Very good.
CD25 positive will be CLL, 23 negative. 23 negative will be mantle cell, and
Very
also
good.
cyclin D1 and SOX11, which will be positive in CLL.
Excellent. Okay. So I
And-
think you are very clear about CD, so we won't spend more time on that. So what is your final diagnosis going to be in
Ma'am,
this?
Shailesh sir, sorry for interrupting. It's
Sure.
it is 8:30.
Okay.
We can
So we'll
maybe
just
take
5
another
minutes
few
we'll
minutes
stop.
more, ma'am. Thank you.
Sure. So what is your final diagnosis here? In one line. Complete diagnosis.
NHL follicular lymphoma stage 4 grade 3A.
NHL follicular lymphoma grade 3A, because you need to complete your histology first. Non-Hodgkin's
grade
lymphoma, follicular lymphoma grade 3A, stage
4.
Stage 4. Okay. Fine. So just to wrap up, last question. I'll give you a few treatment options. So what you would choose for this patient? 1, active surveillance. 2nd, radiotherapy. 3rd, single agent rituximab. 4, chemoimmunotherapy with bendamustine rituximab. 5, chemoimmunotherapy with R-CHOP. We are all trained to MCQs, right? So what would be your choice in this particular patient?
Chemoimmunotherapy with bendamustine rituximab.
With bendamustine rituximab. Okay. Why do you think bendamustine rituximab is fine?
Because they have
If
shown
I
in
say I want to give R-CHOP, I won't give bendamustine rituximab. Will you fight with me, or what will you say?
no, ma'am, it's 3. If it's 3B, no doubt there will have been R-CHOP grade.
Okay.
Since 3A, we can.
Okay. So do you have any evidence to tell you that BR is good enough and you don't need R-CHOP?
Still trial and right trial.
Okay. What is this still?
Bendamustine rituximab was compared with R-CHOP for 6 cycles.
Very good.
Showed a PFS progression-free survival benefit, which was 70, about 70 months in bendamustine rituximab and about 30 months in.
Very good. Excellent. So BR and R-CHOP both are good options. Personally, I would go for R-CHOP because it looks like a very high-grade disease, but that is fine. Whatever you say, you should substantiate it. And if your discussion goes till the level of a clinical trial, most of the time you won't reach the level of a clinical trial. You will be stuck in your whatever lemon and gooseberry and all that. So that's what I said. You have done a beautiful examination. If you reach the level of clinical trial, that means you have done a great job. You have reached the level of a distinction. So that is what I told you. So be confident. If you don't know something, just say that you don't know. I don't say that you have answered 100% of my questions, right? You couldn't answer many of them. I was answering, I know. But at the end, you were able to reach a point where you could reach examination because that is your strong point. You answered CD markers so beautifully, right? You answered B-cell ontogeny so beautifully. At my DM time, I'm sure I would not have answered it so well. So that is your strong point. So get till your strong point at the earliest. Don't get stuck in your gooseberries and lemons. Understood? And then your performance status. So that is the importance of case presentations. Practice case presentation. That is the most important thing. Then only you will be confident. You will not have the luxury of getting your case before so that you can read up about follicular lymphoma. You will have 25 malignancies in your head when you go for your final exam. So have a clarity of thought And that is the most important thing. Nobody is testing your knowledge. Your clarity of thought is what is being discussed and is what is being tested in your exam. Keep practicing. That is the most important thing. As a DM student, I was very scared to present to my examiners, to my consultants, because I would think, what will the consultant think if I don't answer properly? So what you can do is take an imaginary case, write it up in the defined time, present it to your friends. That is one thing you can do. Second is you can stand in front of a mirror and keep practicing. Third is you have your recordings, right? You can record your own presentation, listen back to it. So there will be a lot of and a lot of interruptions in between. So you can practice on your own and improve your presentation. Anything else, Dr. Shrilesh?
Nothing, Deepa. I think it's a very good, teacher class also for me. It's a very good discussion. Just one thing, Gopika, why you said it is a stage 4 disease?
Sir, it's a disseminated disease with omental peritoneal mets, then intramuscular deposits.
Okay, yeah. Because of the extra nodal involvement, right?
Diffuse
Cutaneous extra nodal involvement, right? Yeah. Then what are the extra nodal sites? Spleen. Is it that is a usual question.
Aldes, ring, spleen, and thymus are nodal lymphatic regions, not extra.
Yeah, very good. So, is there any stage 3E in New Lugano? Stage 3E?
No, sir. No,
No
only
stage 3.
One
Okay.
and two only.
Okay. E is not, if there is an external site with the node above and below, it is stage 4. Okay.
Stage 4.
Yeah, very good. Then one more, I think the last question regarding the treatment, it's a treatment is basically chemoimmunotherapy. You can say either as rituximab, bendamustine or rituximab chop. But the problem here is I think the still study and all the only majority of them were at grade 1 and 2. Yeah, I think you can go back and read. I am not sure. So you can just, that trial was done in basically in, I think, grade 1 and 2, BR versus R-CHOP, BR was superior. But again, for this patient, like Deepa mentioned, I think I would go with R-CHOP because it looks like a aggressive disease, like high LDH, this kind of bulk, extra nodal diseases. So basically, my preference would be R-CHOP rather than BR, but BR is not a wrong answer.
Yes.
So since you spoke about the STILL trial, no, STILL is study in indolent lymphomas. It was not exclusively for follicular lymphoma. It was for all indolent lymphomas, right? So it had follicular lymphoma, mainly low grade. Then it had Waldenstrom's, it had marginal zone, and it had Mandel cell. Out of which, and the primary endpoint there was PFS. And second point, it was a non-inferiority study. It was not powered for superiority. And the conclusion of the study was, 1, BR is non-inferior to R-CHOP in terms of progression-free survival in the 3 histologies, except which one? Except marginal zone. Okay, so that was one conclusion. Second, if you have non-inferiority, what are we concerned about? You need something safer. The side effect profile is different. So what are the side effects you would expect in BR, more in BR, and what are the side effects you would expect more in R-CHOP?
More in BR.
Side effect, we have given BR, no, to many patients. What was the classical side effect with which is so troubling to the patient? They'll keep coming and we'll say it's okay, and console and counsel them and send them home.
Alopecia.
No.
Yeah.
Alopecia is one reason why people would take BR.
Vomit.
Yes, of course, nausea is there. It's
Nausea.
skin rash. It's skin rash. You give bendamustine rituximab to 10 patients, at least 8 of them will come to you with varying
Itching.
difficulties and stresses of skin rash. Some would be just a mild rash, some would be more severe. And what about R-CHOP? It will have more of neutropenia, more of febrile neutropenia, then neuropathy, cardiotoxicity, all that. Okay. So your final diagnosis was non-Hodgkin's lymphoma, follicular lymphoma, grade 3A, stage 4, AEX, you said, right? Since you brought out the point of Lugano, Of course, for a traditional exam, what you said is 100% right. Non-Hodgkin's lymphoma, follicular lymphoma, stage 4 AEX. But suppose it's a newly passed out examiner. Somebody who has just completed DM and passed out yesterday. That person will say that what you said is wrong. Would be very critical with you. Why? Of course, for exam, you should say this. I'm not saying you shouldn't say this. Anything else? Anything which you should remove from all the alphabets which you narrated? In relation to Lugano staging, I'm telling you. A and B. A and B you will put for Hodgkin or for non-Hodgkin?
A and B for Hodgkin's.
Yes. So for exam, whatever I'm going to tell is not applicable for your exams. For exam, you should still say non-Hodgkin's lymphoma, follicular lymphoma, stage 4 AEX. If the examiner tells you, based on Lugano staging and nomenclature, how are you going to modify your diagnosis? Then 1, A and B, you will put only for Hodgkin. You don't put it for non-Hodgkin. Second, you will not write E there. Instead, you will write E below it as an extranodal site, and you will enumerate the sites of extranodal. Like in your case, you have the intermuscular subcutaneous deposits as E. So put E equals and put the sites. And instead of X, that is bulky, instead you will put X below and say that bulky site is this particular site and its dimension is this much. Okay, so please go back and read Lugano staging, in which case your diagnosis would get modified as non-Hodgkin's lymphoma, follicular lymphoma grade 3A, stage 4.
Yes.
And you can write E and put the extranodal sites, X, write the dimension and the retroperitoneal nodal area. But for exam, please write the whole thing. If the examiner is asking you, you say that. And one thing we missed out, investigations for diagnosis, you said, beautifully you said, you'll do a PET, choose your node and then do the biopsy, you reached a diagnosis. Staging, you did PET CT and you did a bone marrow because it's low grade. The third one, assess fitness of the patient for treatment. What all investigations you would do for that?
Complete blood count.
Yes, all that we've already done. What extra you will do to assess fitness of the patient for treatment?
For if it's ARCHOP, cardiac
Yes.
status,
Very good. Yes. You are giving rituximab.
rituximab, so viral markers, hepatitis B.
Yes, you should rule out remote hepatitis B infection. Now, anything about prognostication?
Prognostication.
Anything you can do for prognostication? I'm sure you will know it for sure.
Flippy one.
Flippy. Okay, that's fine. Okay, what is the Flippy score of this patient? What are the parameters in Flippy score?
Age more than 60. Stage of an average stage of 3 and 4. Nodal size of more than 4 centimeter. Nodal areas more than 4.
Okay.
Hemoglobin less than 12. LDH
Okay.
and upper limit of normal.
Okay, so what all does this patient have?
LDH more than upper limit of normal.
Okay.
Stage 4. To more than 4 nodal areas. So
yes.
3.
So it's Flippy 3. So what does that come? It's high risk.
High
so
risk.
10 years. Okay. What is the expected 10-year survival? That's okay. So you can just read it up, because for every exam it's better if you are discussing about follicular lymphoma, they would ask you about Flippy as well. It's prognostic. It doesn't help you to take a decision on treatment. It's only prognostic. Okay. So anything else you want to add? Any doubts? Can you go to the next slide? Okay. So I think we'll have an objective evaluation of what you have done in the last 1 hour or more than 1 hour. Sorry for the making it a little longer. Next one. Next slide. So that is Osler. Objective. So this is the famous quote of William Osler. Our eyes will never see, ears will never hear, hands will never feel, what our minds do not think of. So we'll have an oscillor here. Next slide. So oscillor is basically an objective, structured, long examination record, which is an objective, like just as we have OSCEs for a long case, how you can make it more objective. So it's not a very standard one, but in medical education training, we are taught this. So if you do it very well, it becomes P plus. If it is just okay, it's P. And if it is not so good, it's P minus. So I think, Dr. Shrilesh, I think you will agree. The pace and clarity of our presentation.
It was a nice presentation, actually. I think she has answered almost in 80% of the questions. So good.
Yes.
She's final year, right? Final year. Govika, you are final year, right?
Yes, sir.
Yeah.
So her pace and clarity was excellent. Communication process was quite good. The correct facts were established. Physical examination, of course, because it's virtual, we trust you and we believe that 100% of what you said is right. And correct findings were established. Appropriate investigations were discussed in a logical sequence. Appropriate management was told. Clinical acumen, again, we trust you. Counseling part was nice and recent advances were also discussed beautifully. So, and of course, the next is the difficulty level of the case, which I think it's not a difficult case, it's a standard case. So for a standard case, you have done quite well. And I would give a P plus for you. Of course, I'm a very benign, positive examiner. So of course, it will be a P plus for whichever student comes my way in future. So all the best. Can you go to your next slide? So of course, don't be disheartened by any of the comments like the gooseberry and all that. So it's just in a positive note, and whatever you have presented is a part of your past. So past is history, future is going to be a mystery. Today, what has happened in your life today is present. That is God's special gift. So it's called a present. So today you have done well. Be happy about it. Be confident about it. But keep practicing and make sure the presentation you do tomorrow is going to be better than the one you did today. And the purpose of the case presentation is not to test your knowledge. It's to test your thought process. And at the end of 1 hour of your case presentation, your examiner should leave the examination hall as a fan of you and should remember you for the rest of his or her lifetime. So that should be the purpose of the case which you present. And it's irrespective of what case you get for your exam. Sometimes you may get a very confusing case, a case which you have never expected for your long case. But be confident, that is what is most important. For me, the long case for my exam was renal cell carcinoma. Just to share my experience, when I got renal cell carcinoma as my long case for DM at TMH, for 1 minute I thought I'm gone. I'm going to fail now because obviously I have not prepared for renal cell carcinoma. What I was thinking good about was maybe it would be metastatic. Not good for the patient, but of course good for the student. Because as a medical oncologist, metastatic disease is my strong point. So my patient was an engineer, a well-educated person. The history he gave me was, I had hematuria. On examination, I have varicocele. He has read everything about kidneys. I have a renal mass, which he has read up, that it's bellotable, bimanually palpable. I have a renal mass, and imaging shows that it is a renal mass. A DTPS scan is done to show that the other kidney is functioning normally. A bone scan is done. I'm non-metastatic. I'm posted for surgery tomorrow. This is exactly the history I got from my patient for my DM exam. You won't believe. So I couldn't cook up and say something else. It's an educated engineer that's why I said profession is important. So I couldn't cook up anything. My history examination was over in 10 minutes. So I thought for 1 hour, they're going to grill me about operable renal cell carcinoma, for which I know very little. But fortunate for me, the discussion was not on operable renal cell carcinoma. Discussion went on to PET-CT, to PNET, to Wilms tumor, and I don't know where all the discussion went for 1.5 hours. So be confident, have your presence of mind. What case you get is immaterial. So don't lose your confidence, be confident and keep presenting. Next slide. So all the best. Next slide. So always practice presenting. Next slide. Always practice presenting, not as an individual. So catch hold of your friends, your colleagues, and keep presenting as a team. Not for your exam, of course, for exam, you're all on your own, of course, with God's grace and blessings and prayers of your patients, that's all. But till the day of exam, keep presenting cases to a team. The team can be anyone. It can be a first year PG who has just joined yesterday. I can tell you, I discussed a case with my first year PG student yesterday. And the best way to learn at any level of your career is to teach. So whatever you read is fine, you will forget, but you keep teaching. Teach anyone whom you find on the way. They might get so irritated with you that you are teaching them all the time, but touch hold of someone and teach whatever you learn, and you will never forget. So God bless you. So all the best for your future. That's all. Anything else to add?
Thank you.
Nothing, Deepa. Nothing, Deepa. I think she did very well.
Yes.
I think everybody is asking in the chat box that you should be the next examiner also. I think.
No, I've never been an examiner in my life. I'm so tensed when I become an examiner. If a student doesn't answer, I think I'll be more tensed than the student. Because exam is just a single day in your life. It can go either way. So don't be tensed. Please don't learn for the sake of exam. I'm not talking philosophy. Take exam as just one day in your life. You have all your life to learn oncology. It's a whole ocean. You learn before exam, you learn after exam. The only interesting thing is 90% of what you learn is before exam. After exam, you learn only 10%, and that too specifically for the patient who is sitting in front of you. So make use of the next 1 year you have before exam, not for the sake of exam, but because that's the best time to learn maximum of oncology before your exams. And exam, take it just like any other day. As I told you, you are in a busy OPD, you have your consultant, your professor. Suppose your professor is in another room and you are discussing the case with your professor on phone. You will not say about irrelevant things, right? The examiner won't, the consultant won't have the patience and time to listen to small things. So just imagine in that mindset, be brief, be clear, be confident, and say your history and examination in the shortest possible time, so that examiner doesn't stop you in between. Just keep speaking, be confident. When you stop, the examiner will interrupt you and start asking questions. So begin with the end in mind. Have your differentials ready in your mind. There's no right or wrong in your differentials. Whatever differential you say, be confident, have plus and minus for that, and just speak it out. And begin with the end in mind, be confident. If you don't know an answer, please don't beat around the bush. Just say that I'm sorry, sir, I'm sorry, ma'am, I don't remember. The examiner would go to the next question. I don't think there would be any examiner. Of course, examiners won't be as benign as both of us, but I don't think there would be any examiner who would come with the intention of failing you. All examiners come with the intention of passing you. So it's your art. The art of presentation is not just your knowledge. It's about navigating your case through your strong point to reach your diagnosis, differential diagnosis, so that you can reach the point of diagnosis, planning of investigations, and management. And if you reach the level of still trial, you can rest assured that you have definitely passed, and not just a sada pass, but a golden pass. Okay, so all the best.
Thank you, ma'am.
Well presented, Dr. Gopika. Thank you, Deepa madam and Srile sir, for the excellent presentation. I felt very guilty announcing the time limit, and it was very excellent thing. Over to you, Boban sir. If you're here.
It was a very nice discussion. It was
Independent
expected from
nature.
Dr. Deepa. Once Deepa is an examiner, everybody learns, not only the student, but even the so-called teachers. We are all teachers now with DNB starting in all centers. It was very useful for us also. So thank you all. So we are calling it off for today. Thank you, Deepa and Dr. Srilesh.
Wonderful class.
Yeah,
Deepa madam, it was wonderful. Sujit here. Excellent
Sujit.
class. Yeah, great presentation. Also, nice class actually. Thank you very much.
Deepa, there has been some students asking you to take up some classes. So I hope Ampok will be taking up this initiative. Will request you, and sometime in the future, it will be a great
Sure,
honor
sure.
if you can respect that decision of Ampok. Thank you.
Sure, sir. It
Okay.
would be my
Thank
pleasure, sir. Thank you, sir.
Okay. Thank you.